Good afternoon, everyone, and welcome to today's information sharing webinar. My name is Grace Suba, and I'm one of the managers on the implementation science team here at the Registered Nurses Association of Ontario. And as I said earlier, I'm going to be the moderator for today's webinar. I'd also like to introduce you to Andrea Stubbs, and she's the project lead of the Best Practice Champions program. And she'll be online behind the scenes for anyone who has any technical problems or questions in relation to today's webinar. So just wanted to let you know that these are monthly webinars, and it's a means of supporting RNAO's best practice champions in their work and guideline implementation. And so all of the speakers that we have throughout the year are those who are actively involved in BPG implementation. And today we have a presentation from Lakeridge Health on Purposeful Rounding, a proactive approach to decreasing the incidence of falls. So before we get started, just want to share a few housekeeping items to keep in mind. First off is we really want our webinars to be interactive and to be engaging. And so the presenter may ask you some questions during the presentation, but if not, we always have 10 to 15 minutes at the end of the presentation for question and answers. And so we encourage you, whether during the presentation or at the end of the presentation, to type in to all attendees as well as panelists the question or comment in the chat box during your presentation. And then also we wanted to let you know that we are recording these presentations and they will be archived for future viewing on the RNAO website. And so please note, if you participate in the chat box, there is the potential that I'll read out your comments and questions, perhaps your name. And so if you do participate, this will be implied consent that you will be recorded and posted on the RNAO website as well. So it is my pleasure to introduce to you our two speakers for today. Sherry Campbell, she started her career as a registered nursing assistant, and she has a desire to increase her knowledge, which has resulted in completing the registered nursing diploma and critical care certificate, her Bachelor of Science in Nursing, Bachelor of Education with an adult focus, and then finally her Master's of Science in Nursing. Over the course of her career, she has provided care for patients in long-term care, the medical cardiac unit, and critical care. And she shares her knowledge and expertise by facilitating educational opportunities through Durham College, Humber College, University of Ontario Institute of Technology, and as an ACLS instructor. She currently works at Lakeridge Health as a clinical practice leader for interprofessional practice and the critical care unit, and she is the BPSO lead for Lakeridge Health. Sandy, her colleague, started her career as a registered nurse in 1996, and she obtained her certificate in nephrology nursing in 2012. Over the course of her career, she has provided care for patients in long-term care, medical nephrology unit, nephrology program, and currently as a clinical practice leader for interprofessional practice. Sandy shares her knowledge and expertise by facilitating educational opportunities through the development and integration of best practices throughout the organization. So for those of you who are not familiar with BPSO, it does stand for Best Practice Spotlight Organization. And so these BPSOs are healthcare and academic organizations who are selected by RNAO through a request to proposal process to implement as well as evaluate the RNAO BPGs. So it is quite a dynamic partnership that focuses on making a positive impact on patient care, resident care, individuals through the use of evidence-based practice. And RNAO provides support to organizations who have formally agreed to enter into a 3-year period with RNAO. So those are our two speakers, and now I have the pleasure of passing it on to Sherry and Sandy. And so Sherry and Sandy, I will give the mouse control to you now.
Great, thank you very much.
You're welcome.
So hello everyone, and welcome to our presentation on Purposeful Rounding. My name is Sherry, and I'm going to start the presentation, and then I'm going to hand it over to Sandy. Okay. Oops. Sorry. Can you?
It's okay. Here, I will reset it. I'm going to delete that. I'm going to reset it from current slide and okay. So just try to hover it over the arrow.
Sorry, Grace, have you given Sandy?
Here.
There we go.
There we go. We got it.
Okay.
Oh, great. Thanks.
No problem.
Always having some technical issues. Okay. So to start out with, we want to introduce you to Lakeridge Health. Lakeridge Health is comprised of 5 hospital sites. Throughout these sites, we support patients who require medical or surgical services. We also have a women's and children's program and an expanding inpatient mental health department, as well as emergency and critical care units. Lakeridge Health also has post-acute care specialties, which we refer to as the PASS program. And this program includes complex continuing care, palliative, and inpatient rehab units. There are also several outpatient specialties that Lakeridge Health supports, such as the dialysis clinics, oncology services, diabetic clinics, just to name a few. Lakeridge Health has one of the broadest and most comprehensive range of acute care services in Ontario and provides healthcare to the region of Durham, which includes Clarington, Oshawa, Whitby, Ajax Pickering, Uxbridge, and Brock. I'm going to start out with some background information on falls to understand why it is an important initiative. And the main reason is that falls is one of the most common yet potentially preventable adverse event experienced by patients in hospitals. I'm going to review some of the top 3 negative adverse outcomes in relation to falls from an institutional as well as a patient perspective from the research. The main obvious one is the physical injury that can happen because of a fall. This can be in the form of a fracture, head trauma, bleeding from a wound in which sutures are required, or the need to have surgery. All of these could drastically change the quality of life of the patient who fell. Emotional trauma can transpire to the patient and family having to deal with the negative outcomes of a fall, especially if the patient's health state gets worse and the patient dies due to injury from the fall. There is also the potential for the patient and family to experience a lack of trust towards the staff and the healthcare organization due to the injury to the patient. If the patient is able to go home but has more care demands than before the fall, there is potential for the caregiver burnout and feelings of guilt for not being able to look after their loved one anymore. This may result in emotional turmoil if the patient now requires admission into a long-term care facility. If it is an elderly couple who have lived and supported each other over many years, the separation may have negative outcomes to both. Financial issues can also happen due to a patient having a fall within a healthcare facility. There is a lot of literature to support the financial drain to the healthcare system in the form of increased length of stay, cost of increased care demands and services, or potential litigation issues. However, there could be a financial burden to the patient and family as well, especially if the patient who fell is currently working. This is because being in the hospital longer can mean not getting back to work and therefore have decreased potential to earn income to pay bills, or being able to go back to work in the same capacity as before. For the work environment, there might be specific restrictions or accommodations that may need to be put in place to support the person going back to work. For the elderly population where a fall has caused a loss of independence, admission into a long-term care facility can cause financial burden as well. This is due to the pension of the patient going into the long-term care home be shifted to the facility. For the partner living at home, this could result in the loss of funds to maintain their current quality of life and may end up with financial constraints. Many of these negative outcomes were taken into consideration when Lakeridge Health started to look at our corporate falls rate, and it was identified that this was an area that we needed to focus on. In the graph on the right-hand side, it displays our falls rate starting April 2018 to July 2018. As a result of this graph, the senior management team endorsed a sponsorship and utilization of resources to focus our energy on decreasing the incidences of falls. Around this time, in April 2018, Lakeridge Health was awarded by RNAO the opportunity to become a best practice spotlight organization, and this enabled us to utilize RNAO's resources and establish a partnership to ensure that we had at our disposal the most current, up-to-date research available to help us meet our goal of decreasing falls. In reviewing the RNAO best practice guideline, preventing falls and reducing injury from falls, the recommendation of 5.3 stood out. It identified rounding as new within the best practice guideline and had a high level evidence to support. It simply reads, implementing rounding as a strategy to proactively meet the person's needs and prevent falls. Rounding is already part of our practice within the hospital setting, and it seemed like a simple enough process to be able to implement. When we reached out to other organizations, we found that long-term care facilities had implemented this rounding philosophy more so than acute care hospitals. We quickly realized that rounding was more involved than we thought. The literature review conducted enlightened us further in understanding the complexities of purposeful rounding. We began to understand that purposeful rounding is a systematic process of rounding and is an intentional act conducted with a clear purpose and value for the patient's benefit. The understanding of purposeful rounding began to change the format of what we currently do at the bedside, which is a task-focused activity and goes beyond quickly checking the patient and asking, how are you doing, or can I get you anything? As I was reviewing the literature on purposeful rounding, I felt that the structure of purposeful rounding had two main elements. The first one focused on timing, and the second was communication with actionable requirements. Historically, when we look at timing of nursing rounds, this was done at the nurse's convenience. Part of the structure of purposeful rounding is a practice of making scheduled visits to the patients. Some facilities do this hourly, but Lakeridge Health decided that doing purposeful rounding will be completed by the nurse every 2 hours. This 2-hour time frame was set to give the nurse an achievable goal within the hospital setting. For the patients, the understanding that a healthcare provider will be doing rounds on a regular basis gives them a sense of support and attention required while they are ill and are willing to wait for the nurse to arrive to meet their needs instead of using the call bell. This results in fewer interruptions for the nurse between rounds and allows time for the nurse to work more productively, which assists with time management. Purposeful rounding is a simple way to give more structure to our communication and a way to meet the patient's needs proactively. These needs are what we refer to as the 4 Ps, and they are pain, position, personal needs, and personal environment. It was around this time that we changed the terminology from purposeful rounding to P4 rounding to assist staff remember the 4 main elements during patient interactions. It's been highlighted that during P4 rounding, the nurse asks structured questions to the patient, such as, are you having any pain? Do you need to be repositioned? Would you like assistance going to the bathroom? Is there anything you need right now? And checking the patient's personal environment for safety measures to ensure that everything is within the patient's reach, such as the call bell or the telephone. These questions and interventions assist the nurse in performing specific nursing interactions with a goal to improve patient outcomes by addressing the needs of the patient in a proactive manner, and makes the nurse's interactions thorough and purposeful by structuring the time spent with the patient. These interactions, known as anticipatory help, means that support is given to the patient before the patient realizes there is a problem or need for assistance. Falls are decreased because the patient is not trying to go to the bathroom without assistance, reaching for objects that are not close by, or becoming frustrated because a call bell isn't being responded to in a quick enough fashion. Decreasing falls is not the only positive outcome highlighted within the research, but also identified that purposeful rounding is a series of activities designed to promote patient safety, improve patient outcomes and satisfaction, and enhance care delivery. This is highlighted when the nurse who completes regular P4 rounding has the opportunity to get to know the patient and can begin to see any changes when assessing for pain or elimination needs. These changes help the nurse to detect an alteration in health status that assists in early detection of a potential medical concern. Another added benefit is that pressure injuries, skin integrity, and circulation are addressed during regular position changes during P4 rounds. To sum it up in one sentence, purposeful rounding is patient-centered, purposeful work that proactively meets the patient's needs during regular P4 rounds. Due to the nature of changing the structure of rounds, it was decided that this initiative needed a comprehensive educational rollout plan focusing on our medical, surgical, and past programs. The timelines had to be fluid, meaning that we adjusted the rollout to meet each patient care unit needs due to the intervention or department priorities to ensure that staff receive the support and understanding the required structure for completing 4P rounding. The implementation process for P4 rounding has taken approximately 14 months from when we started from the pilot units to completing the implementation phase across all of our 5 Lakeridge Health sites. I've finished my part of the presentation and I'm just now going to hand it over to Sandy.
Thank you, Sherry, and good afternoon, everyone. Here we go. So, oops, went ahead of myself. So the way we started out this rollout was we selected 7 pilot units across our organization, which were all medicine units. We collected Campbell data, which was audits for 5 weeks and about 40 hours in total. And that was in part to determine how many calls were actually associated with the 4 Ps. And additionally, we wanted to leverage this data for staff buy-in because we also continue to collect Campbell audits throughout. And so just speaking to our first pilot unit, when we conducted the Campbell audits, it showed that 73% of the calls, and again, this was pre-implementation, were actually associated with one or of the collectively for the 4 Ps. We then focused on education, again, really stressing how this was a proactive versus a reactive approach. Educational sessions commenced about 5 weeks prior to implementation. We had frontline staff on our working group as well. And during the education session, the way we started it off was with a pre-implementation quiz, really to assess what our staff's perception of rounding was to them or meant to them, which was actually quite interesting. We then also conducted a post-education survey, and we did this anonymously via SurveyMonkey because we wanted to ascertain how the education sessions went. So finding areas of strength, what staff liked, and of course areas to improve. And throughout all of these pieces that you're seeing on the slide there, we PDSA'd all of our cycles. And then we also conducted, I already mentioned that, we conducted this PDSA cycles and made changes per the recommendations and suggestions from our staff. One of those was documentation. So the way we had initially set out our documentation for 4 Ps evolved. We learned that really quickly based on the feedback that we had received from staff. Communication was definitely a major focus, not just for each other as colleagues and our other healthcare disciplines, but I'll say more so, in my opinion, was for the patient and the families. Again, speaking to Sherry's earlier point, that it was really, really important that our patients and their families understood that their loved one was going to be looked after in a consistent manner and at regular intervals, which we knew would help reduce anxiety and fear. And so as a result, we developed patient pamphlets and posters. Posters are on every single unit. Pamphlets are presented to the patient and or their family on admission to the unit, explaining exactly what purposeful rounding is, the frequency, the types of questions we might ask, and the 4 Ps that we will be asking about. This was also very helpful in terms of just being forthright, so that patients and or their families would know that these were deliberate questions or deliberate pieces that we were going to be focusing on rounds, so we could avoid things such as, why do you keep asking me these questions, and those kinds of things. In addition to that, I'll talk more about the patient care standard that we developed, but within that patient care standard, as well as the education, we did some sort of scripting. So just different ways of asking things about the 4 Ps. So instead of just how is everything? Are you feeling better? Those kinds of things. We wanted to be a little bit more specific. And again, these were just prompts. We didn't want our staff to be robotic, but just really trying to illustrate that there are different ways to ask questions that you might need to negotiate depending on your patient population to get the answers that you need versus asking, how's everything? So here it's one of our patients who provided a story. This lady in the bed, and there you can see myself. This is Leslie Motes, our CNE, the manager and the CPL of this pilot unit, and one of our VPs. And so throughout, we kept conducting surveys for staff because we really wanted their input. And as I mentioned, documentation was definitely one of those pieces. We also wanted our staff to know that they were being heard, and this was a partnership. This was not something coming from above, being forced upon them, but really wanted to engage and to develop a mutual trust, respect, and understanding that this was a mutually beneficial implementation. And so after we implemented to the pilot units, we continued to conduct Campbell audits. Again, we really wanted to be able to show the staff, and that was our hope and what we expected, was that the Campbells would decrease for the 4 Ps specifically. A Campbell is a Campbell. We may still have had 500 in a day shift, but now maybe these 500 Campbells were for other things and not for any of the 4 Ps. And the way that we did that was we had auditors come. It was for 5 days a week in a month, so 40 hours, which was really the only thing we could control, was the length of time that we were auditing for. And this occurred at regular intervals, which was month 1, 2, 3, 6, 9, and 12 post implementation. And of note, apologies, we just in the first couple of months, actually the first third month of the first unit that we implemented to, so I had mentioned that I think it was about 72% of the call bells were related to the 4 Ps. So within 3 months, it had decreased to about 37% post implementation. And so with that, and all of our pilot units, we celebrated with our staff. And I think what was really important was that we weren't celebrating in terms of, yeah, you're doing a great job, although they were. But I mean, it was a work in process, and maybe we weren't seeing a shift the way we would have expected, because with change, we know it does take some time to adapt and adjust. We just wanted to recognize staff that you've implemented something new, and we just wanted to thank them for doing it, and that worked out really well, and our staff were really appreciative. And of course, throughout all of this, we developed a patient care standard, highlighting everything that we've mentioned already. So this is just a snip of the call bell data as we collected it, and just showing, you know, in some areas, at least from this slide, how it decreased. So if you look under personal needs here, you can see just for that one part of the P in 3 months, or in 2 months time here, it actually decreased significantly. And then if you look over to personal environment, you can see it kind of started to trend upward. And the good piece about this is that we were then able to see how we were doing or where we were doing well and where we needed to put some more focus on. So in this case, in personal environment, we knew that we needed to shift our attention and ensure and reinvigorate the education in real time as much as possible to illustrate to our staff that we needed to, work on that piece, so to speak. So some challenges and some barriers. So definitely nursing perception to rounding was one of them. And as Sherry had mentioned earlier, we were having lots of feedback such as, well, I already do this. I've done this for 30 years. It's the young nurses that need to know how to round and those types of things. Nursing work habits. So asking staff to recognize and approach their work in a different way to accommodate the 4 Ps, which was really organizing themselves and bundling their care. Rounding forces nurses really to change their habits, and changing habits is hard, as we know. And that was for young and experienced nurses alike, although one influences the other. So when new staff are coming in, they're precepted and influenced by the person that is orientating them. Patient care unit flows and cultures. So again, it was addressing types of patients on the unit. So these were all medicine units that we piloted on, but depending on the unit, because they were unique, they would have different patient populations. Some might have an influx of what's the word I'm looking for? Alternate level of care patients. They might have a bunch of admissions with patients with dementia and those kinds of things. So we really needed to focus on that. And we also had isolation units as part of our pilot. So again, it was really customizing how we were going to round based on the flow and the patient population, sometimes on a given day, depending on the census. Nurses' perceptions of rounding. Again, I touched on how we conducted a pre-educational survey regarding rounding and ascertained what their perceptions were. And we really, again, just wanted to highlight that asking questions such as, is everything okay? And that kind of came through loud and clear, because we also did patient satisfaction surveys, that when we ask a question like that, our patient does not know what they need. In our heads as nurses, we have a whole checklist that is flowing through our minds when we ask those questions, but the person on the other end of that question has no idea what it was that we really mean. So we really needed to focus on asking specifics so that everyone was on the same page and we knew what you were asking and the appropriate response. Additionally, we recognized that there was not consistency for rounding. So even though people were saying that they were rounding, it wasn't consistent. So the focus again of the education was to ensure that there was consistency. And as a pro to the staff, they actually felt reassured. So that was a bit of a win, because they knew that, because this was being standardized, that when they went on break, they knew that their colleagues were rounding on their patients the same way they would be if they were not on break. And of course, the ultimate goal here, apart from reducing anxiety and increasing patient satisfaction and decreasing call bells, was to, of course, decrease our falls rates. We also developed champions to leverage that peer-to-peer support and buy-in. We also identified some, sorry, thank you. We also identified some unexpected interruptions. So it was things such as other initiatives being rolling out or competing priorities. So we proactively planned as best as we could to strategically plan around other rollouts, because we knew that this was really important and we wanted not just to roll something out and have it sort of go by the wayside. We really wanted to make a positive change. And so those were some of the things that we had to do in order to pre-plan. And we wanted, again, to solidify that bundling of care. Also noting that, again, based on the culture, some units, have primary nursing model of care versus a team care approach. So it was really working around that and trying to adjust as much as possible. So here just again a little snip of our outcomes, and this is a corporate graph that you're seeing. So happily, we began to see a steady decline in our falls rate, which was ultimately the end goal. And as you can see, we did pretty well as we take a snapshot here from April of 2017, which was pre-implementation. Our first pilot unit rolled out in September of 2018, with our last unit, so corporate-wide, was November of 2019. I'm also happy to say that this was identified as our organization's greatest achievement for quality improvement on our annual quality improvement plan. And so really where this brought us, or what this graph is really trying to illustrate, is that decrease in injurious falls. Our target was 20%, and I'm very excited to say that we actually decreased our fall rates by 72%. Again, that's from April of 2017 to July of 2020. Our indirect outcomes were that nurses began to actually see the value in purposeful rounding. They could see, and we could show them based on the patient satisfaction surveys, that our patients were happier, they felt less anxious, and their families, knowing that someone was routinely coming in to see them. And I also need to note that when we say we're purposeful rounding every 2 hours, that is minimally every 2 hours. Could be done definitely and is more frequently as required. So yes, we increased our patient satisfaction, we decreased our number of injurious falls, we decreased the number of call bells related to the 4 Ps, standardization, as I mentioned before, and again, minimizing those trips. So staff were happier in terms of their work. And that concludes our presentation.
Okay, excellent. Thank you so much, Sherry and Sandy. I mean, as a BBSO coach, it's been a privilege to watch you and your teams and champions and everyone from bed to board side implement this organizational strategic initiative. And it's just been, it's to be identified as one of the highlights for quality improvement in the for the year is just really impressive. And I just really enjoyed listening to you, the level of engagement that you had included in your planning, as well as in the rollout when it comes to frontline staff and patients and families. So thank you very much. There are a number of comments here. Ooh, hold on. I'm just trying to get to the chat box, but they're all comments as well as questions. And let's see here. Diana's asking, would you talk a bit more about the specific documentation required for nursing staff? It would be helpful to know the journey of how it started and how it had changed based on staff feedback.
Sure, absolutely. So initially, well, maybe I should start by prefacing that at the time that we started to roll this out, so even back in July 2018, we knew that we were going to be, at that point, we're looking at a new information system for our organization. And so knowing that and knowing how big that was going to be, we really needed to work with what we had. And so initially, and again, like I mentioned before, we had frontline staff through every single piece of this journey, including gap analysis. And so we started off by creating documentation that was specific to the 4 Ps. So it was like embedded within in their activities of daily living documentation screen. and it actually had the 4 P's specified, so pain, and it was a yes or a no. Personal needs, environment, repositioning, it would be a yes or a no. And we trialed that. It actually went live. And then based on the feedback, staff just found it to be redundant and actually, to be honest, just weren't documenting it. And so we brought it back to the table and said, okay, you know, what can we do to make this easy? But and so what we did was we still kept it within the same screen, but we made it where they just had to answer it a yes or a no as a whole for the 4 P's, which they only had to document every 4 hours, which coincided with the documentation requirements of that EVL screen. But they had to know that even though you're only going in and documenting every 4 hours, that you are actually doing this every 2 hours. And part of that is we would have sort of spot checks. Their leadership was out rounding with them or just spontaneously popping out to see if this was being rounded. I mean, we tried different strategies, but I'll say that documentation was a big piece. And it was just the way our system worked, where some screens, although they're different, the content that's being requested was similar. So there was a whole talk about double documentation. So that was definitely one of the pieces we had to work through. But once we got to it, you know, things started going well from there.
Okay, excellent. Thank you for sharing. There are a number of other questions. RNAO, and I believe you had touched on this, has it also been implemented in the mental health units?
Purposeful rounding and corporate rides. So yes, absolutely. Yeah. Apart from outpatient areas, all inpatient areas, and of course we're excluding pediatrics because they have their own sort of form of rounding, but all adult inpatient areas, except with some exceptions. So critical care is not doing it. You know, emerge, for example, when patients are admitted in transit to be admitted to a floor. But yes, mental health is purposefully rounding.
Okay, excellent. Diana also had another comment. She said she works in long-term care and never thought to conduct call bell audits. And I believe it was another individual, Michael had said that because she was asking, does anyone know whether this can be done in long-term care settings? And I believe an individual was saying that it depends on your call bell system.
Oh, the call bell, yes. So literally what we did, and again, it was kind of a bit of a barrier because we didn't have any, you know, designated people at our disposal and so really we were begging, borrowing, and stealing anybody that we could to conduct these call bells. So of course we knew there would be, you know, a margin of inaccuracy, I'll say, depending on who was actually auditing. But quite literally, it was sitting down at the call bell, and when the call bell rang, was asking the person if they didn't already preemptively say, and trying to identify if the call was for pain, positioning, personal needs, and personal needs includes, you know, your hydration, your food, your toileting, bathing, and personal environment, such as my phone is across the room, can you go get it for me? And then additionally, what we did was any other call we also tracked. So we categorized that under other, but we teased it all out. So there were things such as calls for IV beeping, calls for patient has returned from a diagnostic test, or patient is beeping because they've been discharged, or those kinds of things. So we really wanted to understand as well what all the other calls were. Partially, we need to know what our denominator was, but we also wanted to leverage that data that could potentially be used for a future change to another initiative or implementing some other initiative based on those results. So that is quite literally how we did it. And then the auditor would input the data into a survey monkey, which then I would then go and check and put it onto a spreadsheet, which made it quite easy to sort and filter. And so that's truly how we did it. There was lots of manual work, but it definitely can be done as long as you have a call bell unit. And we did even track things such as, you know, patients that were confused. So we did make notations for those things as well.
Okay, thank you. We do have 5 minutes and we do have a number of questions, so I'll do my best to sort of highlight the themes here. So there seems to be a number of them in regard to essentially auditing and an evaluation. So Holly and some others are asking, how did you ensure that staff are doing the P4 rounding and asking the new questions, and what did you do to support the change in terms of reminders of what to ask?
So for the first little while, and I'm just being very broad because, you know, every unit kind of did things a little bit differently, but at least for the first couple of weeks to a month pre-implement, well, we really worked it up before. So it was this constant, you know, 4P rounding's coming, 4P, we tried to make it light. And just, that was one of our ways of reminding. The week before, it was being discussed at huddles, don't forget, we're going live on whatever the day was. And then we made sure that leadership, that included manager as well, were around and rounding with staff. So, and then there was a little bit of observational work going on. So where they would, the leadership, and included myself, sometimes I would just pop up to a unit and just, oh, you know, when have you guys rounded? Or are you rounding now? Can I round with you? That was definitely part of it because we wanted our staff to know that this was here to stay and it was important. And additionally to that, it was the patient satisfaction surveys, which did ask questions specifically about rounding. So has someone been in minimally every 2 hours? Have the staff proactively asked you these questions if they asked you about pain, et cetera, et cetera. And so sometimes people couldn't answer because they may not have had a watch, or the clock in the room might not have worked. So we did sort of, you know, have to take it with a grain of salt. But really it was, I think, the presence of leadership on the unit, whether they were rounding with staff or just observing them round, really helped to ensure, because the documentation was not a way, because of the way it was built, not a way of ensuring that it was done. And in addition to that is if we notice things like pressure injuries increasing, or, you know, so we would tie things back because they do have common threads. How are we repositioning this person every 2 hours if they've developed pressure injury type of thing? So we were very upfront about things. And we would also show the data on quality boards. So they would discuss it weekly. We would have things in our leadership forum. So this was on everyone's radar all the time, for sure.
Okay. Yeah.
It wasn't going away.
No, yeah, and it makes sense, and especially in the early stages of implementation, and making it become a part of standard practice, that the need for reminders and prompts and support and encouragement and motivation is definitely important. Okay, so there is, and we're assuming then there was an interprofessional approach to purposeful rounding. They wanted to know more about who exactly was involved in the rounding, and whether you used a checklist or whether it was some other process that you used in order to actually do the rounds.
Oh, so actually we decided not to do a checklist when we rounded. We know some organizations from our Lit Search and reaching out had incorporated things like that. We decided not to because we felt it would not necessarily be accurate. You know, like I could go up to the door and just take a pen and check off that these things were done. Did not necessarily mean that they were. In terms of who rounded, well, again, each unit sort of has a different mix, but primarily I would say it would be the RN, RPNs, and for areas that had PSWs. Now, having said that, that doesn't mean that other disciplines such as physiotherapists and occupational therapists, things like that, weren't assisting, but primarily this fell on nursing.
Okay. Okay, excellent. Thanks for the clarification. And in terms of the pilot in itself, who was involved in the pilot? I know it was one unit that you piloted on first, and then did your finessing before you started to roll it out across the organization. But how many people were actually involved in on your pilot team?
Well, it was more than just a pilot team. So we had some frontline staff members from the units that we knew we were going to roll out to. So meaning we preemptively knew that we were going to roll out to 7 units. and across the organization. So we kind of picked one, and incidentally, we chose the area. I say incidentally, truly, because at the time when I started was planning this out, I wasn't really looking to see who had the highest fall rates, but truly that's actually how it ended up happening, was the unit that we piloted first to have the actual highest falls rates. But we knew we were piloting to 7. So we had frontline from as many of those 7 units that we could get. We had the clinical practice leaders, and then of course management, and I mean right up to senior management were involved in some way, shape, or form, because we knew that this was going to be big for our annual business plan in terms of fall. So everyone is definitely engaged and involved in that, if that answers the question.
Okay, yeah. Hopefully it does, Jay Park, that it answers your question. Realizing it's 12:46, because this is being recorded, I think I'm going to ask just a few more questions. I realize that some people have to leave, but please do so. It will be posted also on the RNAO website, and perhaps some of the questions that you haven't been able to listen to will be, have been recorded. So I'm just going to take just another 5 more minutes, Sherry and Sandy, if you don't mind, just because there's a lot of great questions here that I want to be able to capture.
Yeah.
And can you share some ideas of how you were able to sustain the change? So this is one of your earlier BPGs that you implemented. It's now organization-wide. How have you been able to sustain these changes?
So one of the ways that we're sustaining is that leadership from each unit actually has to audit. And when I say audit, it's not call bells. We only did that for a year for each pilot unit. And as we spread, we did not do any pre or post implementation call bells, because we've sort of proven our point that, I think that kind of speaks to it. We'd already kind of proven that this works in terms of call bells. And so every month, a patient satisfaction. So again, it's part of that whole observational, because it's the leadership or a designate that will actually go in and survey the patients to ensure, so that it's not the nurse doing it at the bedside where it could be sort of skewed. So it's leadership. So that's doing it, and they put it on a spreadsheet, and then I just check to make sure that it's being done. But I think really what speaks to the results is the fact that our falls rates have decreased corporate-wide. And the way we have our data, anyone can go in and look to a specific unit to actually see how their fall rates are for that specific unit. So I think that truly is what speaks to the success. Or if you start to see that the fall rates are starting to creep up, you're going to have to focus and try to identify why. We also, and I'm the chair of it, is we have a falls working group, which we have leadership, we have membership from quality and risk, we have frontline staff from all different areas corporate wide. And what we do, we worked as a group to develop the policy and things like that, but now really the focus has shifted to them, so they will present. So it's having those frontline staff working in collaboration with their leadership, especially not just for fall rates if they've gone up, to identify what we think happened and what can we change or what was different to lead to this. But we also, I'm going to say, call out areas that are doing exceptionally well and saying, what do you attribute these changes to apart from, X, Y, and Z? Like, what do you see as being unique? So we really, really are trying to have everyone engaged, and I think that definitely is part of the success.
Okay, excellent. No, and it's a testament to you, it's still going on strong, and congratulations to your teams and to the champions for doing this. Let me cover, one more question, because there's been a number of people from long-term care who were wondering about the adaptation of purposeful rounding to the long-term care setting. You had selected to do rounding every 2 hours. Any sense of, of the recommendation and its adaptations to the long-term care setting?
So again, because it's a patient care standard, so for our long-term care setting, again, the minimum is 2 hours. Having said that, and again, it can be slightly adjusted because if someone has dementia, for example, so I would say sometimes the questions may not be appropriate to ask, but in that case, we're using our clinical judgment. So if your person looks like they're having pain, although they might be denying that they're having, they might not understand what you're asking. I mean, it really is a holistic approach, and that's in our standard patient care standard as well. It's yes, for the people that that are cognitive and can answer these questions for you. Of course, you know, these are some ways to do it, but you still need to use your discretion and your critical judgment to assess your patient, whether they're cognitively impaired or not. It could be somebody who just had surgery and is sedated and they're moaning and groaning, but maybe can't speak to you right now. Yeah, these behavioral pieces that you're looking for. So, you know, that might be the more of the focus for a long-term care setting, but it can also be used outside of that setting.
Okay, excellent. So I think we are pretty much done with the questions. There was just like, I think I covered most of what everyone had wanted to talk about. And just Lily, just in terms of sharing at Trillium Health Partners, they do the 6 Ps. So having to pain, positioning, proximity, pumps, personal, and promise to return. So as you were saying, there's different adaptations to it, 4 Ps, the 6 Ps, and also ways to be able to adapt it in long-term care, as well as here, acute care, because we've often heard it in long-term care. So we wanted to highlight its use also in an acute care setting. So thank you very much, everyone, for participating and for the lots of wonderful questions. Sherry and Sandy, as always, it's a pleasure to chat with you, and thank you so much for sharing your wisdom, your experience, and your experiences with BPSO. We very much appreciate the contributions that you've made to your organization and to ultimately patients and families. So thank you very much, everyone, and have a great day.
Thank you.
Thanks.
Bye. Thank you.
Take care.
You too.